This video is created for educational purposes and should not be used as medical advice, and is based on an article that's published in the American Journal of Case Reports in March 18, 2025. It was supposed to be just a normal stomachache, nothing more, but for this 45-year-old woman, the pain had other plans. She had been suffering from lower abdominal pain for 7 days, specifically in the right lower quadrant, and the pain wasn't going away. Along with it came the swelling. Eventually, she made her way to the emergency department. The pain was dull, constant, and moderate in intensity. She thought the distension was secondary to chronic constipation, but remarked that a bulge inferior to the umbilicus had grown dramatically in the last 4 days. She reported subjective fevers and chills, and she denied pain radiating to the back, dysuria, hematuria, hematemesis, or hematochezia. She was a known case of chronic pain syndrome treated with opioids, gastroesophageal reflux disease, and hysterectomy. Physical examination in the emergency department revealed a febrile patient in mild distress secondary to pain. Vital signs revealed a temperature of 38.5, pulse rate 89, respiratory rate 20, blood pressure 118/77, and oxygen saturation 99%. Upon physical examination, there was tenderness of the right lower quadrant and the midline of the lower abdomen, but there was firm swelling near the umbilicus extending to the suprapubic region, with no bruises or hernia. Her labs came back with one red flag: elevated white blood cell count, but nothing too dramatic. So they did a CT scan, both IV and rectal contrast were used, and here's where things get confusing. There was an abscess, alright, but in the abdominal wall, no signs of obstruction, no classic signs of appendicitis, no visible perforation, even normal-looking appendix. These are a few of classical CT scans of appendicitis which are not found in our current case. The first image shows appendicular abscess which was caused by perforated appendicitis, and the second one shows acute appendicitis, dilated tip with fat haziness. And the third image shows appendicular, which is specific for appendicitis in around 80% of cases. And this is intraperitoneal gas in a case with perforated acute appendicitis, which was not found in our current case. With no clear intra-abdominal source found, the team proceeded to incise and drain the abscess using laparoscopy, but there were dense adhesions near the peritoneum. This wasn't just a superficial abscess, so they switched to open laparotomy, and here's what they discovered. The appendix had perforated, and it was stuck to the abdominal wall. Here, a fistula tract had formed from the appendix to the abdominal wall. That abscess, it wasn't random. It was draining from a hidden perforated appendix. Histopathology confirmed the suspicion: perforated appendicitis with inflammatory cells. So what exactly happened here? Let's take a step back. The appendix is a small finger-like pouch extending from the cecum. In most people, it sits in the right lower quadrant, but the position can vary. One of those positions is retrocecal. Acute appendicitis is one of the most common surgical emergencies. About 100 cases per 100,000 people per year. Perforation happens in up to 35% of cases. In retrocecal appendicitis, when inflammation leads to perforation, the infection doesn't always spill freely into the abdominal cavity. Instead, it's sometimes even forming fistulas or abscesses in unusual places. Following the procedure, the patient was sent to the intensive care unit, then returned to the operation room for re-exploration of the abdominal wall and further debridement. She recovered well after the operation. The abscess resolved, the source was removed, and the unusual presentation gave the team a case to remember.